So I'll be speaking about multimodality imaging and genetic insight in the mitral valve prolapse. Let's see if this works. Okay. So this is a real case that happened in our hospital. A 27-year-old resident, she fainted in the CCU rounds while presenting to her attending. The follow-up Holter showed a non-sustained VT, for which she was subjected to a CMR after echocardiography. And on CMR, she was found to have severely dilated LV. There was also dilatation of RV. As you can see, there is bileaflet prolapse of the mitral valve. There is also mitral annular disjunction that we are going to speak about today. The distance for the mitral annular disjunction was 12 millimeters. There was no late gadolinium enhancement found on the CMR. And on echocardiography, let's see if it can play. Yes, so on echocardiography, you find similar findings with bileaflet prolapse, but also on 3D imaging, she has severe mitral regurgitation. So this is a previously healthy female who was suddenly diagnosed with non-sustained VT after an episode of syncope. So this patient comes to the clinic, and I think these are the questions that we should be answering as clinician. So what's her heart failure risk? What's her arrhythmic risk? And what the management does she need, apart from the obvious, which is, of course, here, the mitral valve repair. So the objectives of my talk are, we are going to discuss different imaging modalities that are used in diagnosis of mitral valve prolapse. We'll further summarize the current knowledge about the genetics of mitral valve prolapse based on the classification that's currently there. We'll also describe cardiovascular imaging use for the non-diagnostic morphologies that exist for the pedigree in the familial form of mitral valve prolapse. And finally, we'll see how we can prognosticate these patients effectively with cardiovascular imaging. So I would like to make a statement. Mitral valve prolapse is not one disease. It's actually more than one form of, a disease. And why that is because, of course, we have the standard definition. This was, derived from the Framingham criteria, and that is superior displacement of the mitral valve into the left atrium, more than 2 mm in systole. And then you need thickened valvular leaflets, which are up to 5 mm in thickness to make the diagnosis. But then more than that, we all have seen these patients with fibroelastin deficiency. There is absence of excess tissue. There are thin areas in leaflets. There's frequent chordal rupture. And frequently with FED, you don't have that much annular dilatation. Opposite to that is Barlow's disease, which has excessive, tissue. It has enlarged leaflets. It has enlarged annulus, and it's quite deformed mitral valve. So I can tell you that the risk that you see with FED versus with Barlow's is different, and we'll discuss why it is different. So let's go to the second part, which is we are going to summarize what's the knowledge that exists when we look at the genetic of mitral valve disease. So, of course, mitral valve prolapse is a genetic disease. So we all have seen those syndromic patients, patients that have syndromic mitral valve prolapse that's seen in Marfan's, Louis-Dietz, and Ehlers-Danlos syndrome. But then there is familial type, and that's the non-syndromic mitral valve prolapse. So I'd like to remind you, so in the non-syndromic familial type, you can have autosomal dominance inheritance, or you can have X-linked inheritance. And some of the genes also are responsible for dilated cardiomyopathy or LV non-compaction. So it's very important to remember that every time you see LV dilatation in a case of mitral valve prolapse, it doesn't always have to be because of mitral regurgitation, since it can also happen because these genes are, phenotypically also present with dilated cardiomyopathy. So more importantly, with all these forms of genetic forms of mitral valve prolapse, there is no pathological pattern that is specific to the disease by genetic background. So, moreover, if we look at who should we screen, who are these patients and who should we screen? So what they did was they followed families of patients with mitral valve prolapse, and these incidents were found by that. So overall community incidence of mitral valve prolapse is 1%. But when you look at the offsprings of these families, it's actually way higher percentage of mitral valve prolapse. Again, if you look at the FED patients, the occurrence of mitral valve prolapse in that cohort is 8% versus 26% with Barlow's, which makes you the number needed to treat to screen for these patients would be between 4 to 12. Now, so who should we screen? So, of course, syndromic mitral valve prolapse patients, they all should get genetic counseling, and they also should be screened. What about the non-syndromic familial type? Right now, there are no guidelines based on that, but there are some consensus statements that you can look up, and it recommends that if you have a familial type of mitral valve prolapse at age 18, you can screen the first-degree relative with an echo, and thereafter, if mitral valve prolapse is absent, you can repeat the echo every 5 years. So let's speak about how does cardiovascular imaging helps us diagnose what are the non-diagnostic MVP morphology. What I mean by that is, can you figure out the phenotype in the offspring if it is not full-blown MVP yet? So if we look at the natural history of mitral valve prolapse, this paper was written by one of my mentors in fellowship. It starts with normal mitral valve, and then it goes to these non-diagnostic morphologies. And these non-diagnostic morphologies are mainly two. One is abnormal coaptation of the anterior mitral leaflet, and the second one is minimal prolapse of the posterior leaflet into the left atrium. From there, there's full-blown mitral valve prolapse stage where patients go into that, and finally they get severe MR. So this is the natural history that was established by studying these families. And again, if we look at these non-diagnostic morphologies, we can actually monitor these patients more closely to see who goes on to develop the full-blown mitral valve prolapse. So on the left side, you have the anterior abnormal coaptation. So typically the coaptation of the mitral leaflets should happen more, as you can, let me see if I can, yeah. So it should happen, right? The anterior leaflet should be more than the posterior leaflet. But when this is disrupted, where you have more posterior leaflet than the anterior leaflet, then this is the abnormal anterior coaptation. And right here is the posterior minimal systolic displacement. So before a full-blown mitral valve prolapse happens, patients can get this stage. Once they develop this stage, you can actually closely follow up with them to see if they go on to develop mitral valve prolapse, which is seen more in these patients once they exhibit this non-diagnostic morphologies. So now let's talk about how does the cardiovascular imaging help us with prognosis in patients with mitral valve prolapse. So this was a paper again written in Circulation in 2014, and this paper it was again focused on natural history of asymptomatic mitral valve prolapse, and I like this sentence that they put. Which is quite a broad sentence, but MVP is not a uniformly severe or uniformly benign disease. So I know that when I was in fellowship, I have used that blanket statement with my patients and told them MVP is benign, you don't have to worry about it. It's not so. We have to risk stratify these patients very effectively with cardiovascular imaging before we can tell our patients if they are what bucket they belong to. So basically, if we look at the prognostic factors with mitral valve prolapse, the prognosis depends on what kind of myocardium or valvular risk they have, or what kind of arrhythmic risk they have. So with the myocardial risk, I showed you that some of these patients can carry genetics which can be responsible for severe LV remodeling with dilated cardiomyopathy. So of course, if they have that, if they have severe bileaflet prolapse, if they have severe mitral regurgitation, that adds to the risk, overall risk and prognosis. On the arrhythmic side, you can have features like mitral annular disjunction that we are going to speak about. There can be interstitial fibrosis. There can be fibrosis, exhibited in form of positive late gadolinium enhancement on MRI. So let's speak about this. So if we look at, closely what it is, how do you determine a patient's prognosis in cases of mitral valve prolapse. If you have severe degree of MR, if you have cardiomyopathy, if you have left atrial enlargement, or if you have atrial fibrillation, that adds to a risk. On the right side, if you have bileaflet prolapse, if you have mitral annular disjunction, if you have interstitial fibrosis or LV fibrosis, that would add to patients' arrhythmic risk. So how does cardiac MRI help? Well, cardiac MRI helps because it gives us accurate LV function assessment. It also tells you what's the severity of the mitral regurgitation. It also gives you the direction of the mitral regurgitation. It tells you mitral annular disjunction distance. I think I have time, right? Doesn't matter. Yeah. I'm going slow. There can also be, it can also be helpful with ventricular fibrosis. And again, with using the flow data, you can utilize mitral regurgitation fraction very accurately with cardiac MRI. And finally, with the new sequences with T1, T2 mapping, as well as ECV, you can figure out if the patient has interstitial fibrosis. So I think to me, CMR is a complete test, which gives you kind of all this risk stratification in one test, and it's truly the one-stop shop for mitral valve prolapse patients. So what is mitral annular disjunction? Was described by a physician who unfortunately passed away with mitral valve prolapse with severe VT. So in this paper, they first described, it was in 1981, that the annulus of valve was elongated and it was shifted into the left atrium. So what exactly is mitral annular disjunction? It's seen in around 9% of patients, but it's basically this distance that you see between the annulus and the LV wall, and the entire annulus is shifted into the atrium. So this distance can be measured on either echo or on CMR, echo in the parasternal long axis view, in CMR, in the three-chamber view. Remember that mitral annular disjunction doesn't have to be infrabasal. It can be anterior, it can be inferior. Typically in MVP cases, it is seen in infrabasal wall. So it, of course, increases the risk of arrhythmia. So 1 in 10 patients have ventricular arrhythmia when they have MAD, and MAD actually adds to arrhythmogenicity regardless of whether the patient has MVP or not. So in MRI studies, there's a meta-analysis, and it's shown that distance of more than 8.5 mm has been associated with higher risk of ventricular arrhythmia. So is MR, it's the mitral regurgitation assessment using echo enough? I think this paper, this group of investigators, they have done multiple serial studies on this topic, but this paper is very special to. I feel like this was very informative, just published this year. But what they did was they took ASC algorithm for severe MR classification, and then they compared it with the CMR flow data. And what they saw was, let's see, yeah. So if you can see, here is the pulmonary vein reversal, here is vena contracta, all these echo features that we use that has been taught to us for centuries, I feel like, that it is associated with severe MR. Whenever you see, pulmonary vein reversal, there is severe MR. When they compared it with the CMR data, actually 25% of the patients did not have severe MR and still had pulmonary vein reversal. They still had flail leaflet present. And it was actually the CMR that correlated with prognosis. So that showed us echo criteria did not correlate with overall prognosis. It was a CMR criteria. So that showed us that perhaps the assessment of mitral regurgitation in primary degenerative MVP-related mitral regurgitation may not be enough just by echo, and we should truly use CMR for the accurate assessment, particularly before we send these patients to surgery. So I think these are my take-home points. Not all the patients with MVP have benign prognosis, so we should not use that blanket statement. It's not one disease. It's many diseases in one, and clinicians should use all the tools that they have available to recognize all these features. The second thing is it can have familial transmission, and actually offsprings have significantly higher risk of developing MVP. And they can also have those non-diagnostic morphologies that can evolve later on in life to full MVP. And then third is CMR remains the only imaging modality, in my opinion, that can effectively risk stratify these patients with MVP through gold standard assessment of LV function, mitral valve prolapse, mitral regurgitation severity, extent of mitral annular disjunction, and also assessment of interstitial as well as LV fibrosis. Thank you.